I'm Dr. John McGill, faculty in the Emergency Medicine Residency at Hennepin County. Today we're going to be doing an instructional video on the use of the bougie in the difficult airway. This is a classic gum elastic bougie. A disposable tracheal tube introducer is also used in this setting. We're going to be going over the basic techniques and also some of the troubleshooting maneuvers if you're having difficulty with placing the bougie or the endotracheal tube. There are 4 tracheal tube introducers, also known as a bougie, that are available in our emergency department. The classic gum elastic bougie, a synthetic tracheal tube introducer, the straight gum elastic bougie, and the pediatric gum bougie. The classic bougie is reusable, while the synthetic bougie is disposable. They're otherwise similar. The adult bougies will accommodate a 5.5 millimeter endotracheal tube. The pediatric bougie will accommodate a 4.0 tube. For clarity, from here on in, I'll be referring to this airway adjunct as a bougie. Bougie-assisted orotracheal intubation is ideally a 2-person procedure. After the operator obtains maximum laryngoscopic visualization, he or she is handed the bougie by the assistant and advances it into the airway. With the laryngoscope still in place, the assistant threads the endotracheal tube over the bougie, and the operator advances it through the larynx and into the trachea. At this point, the bougie is removed and the endotracheal tube position is verified. A counterclockwise rotation of the endotracheal tube as it approaches the larynx is advised because it will decrease the chance of the tube catching on the laryngeal soft tissue. If any portion of the arytenoids, the most posterior aspect of the laryngeal inlet, can be seen, placing the bougie just anterior to them and in the midline will guarantee correct endotracheal placement. Usually when you pass the bougie into the trachea, you'll feel the click of the tracheal rings as the angled tip strikes against them, confirming tracheal placement. If you're unable to visualize any portion of the laryngeal inlet, confirmation of correct bougie placement must be non-visual, either by feeling the tracheal rings or advancing the bougie to 40 centimeters, at which point there should be some resistance as it encounters the carina, or twists as it enters one of the main bronchi. There is a tendency to remove the laryngoscope after the bougie is placed. This should be avoided because, in the absence of the blade, the hypopharyngeal soft tissue tends to push the bougie and the endotracheal tube posteriorly and results in the tube catching on the arytenoids. The scope must then be reinserted, the endotracheal tube pulled back slightly and rotated counterclockwise as it is readvanced into the larynx. If resistance is encountered when passing the endotracheal tube through the laryngeal inlet, it should be pulled back 2 centimeters, rotated counterclockwise 90 degrees, and readvanced. This maneuver orients the bevel of the endotracheal tube posteriorly and allows it to easily slide over the arytenoids. If the bougie is passed too deeply, the proximal end will lie within the endotracheal tube, making it impossible to secure the bougie before advancing the endotracheal tube. If this occurs, time is wasted as you pull back the bougie to a point where it protrudes out of the endotracheal tube and can be grasped. This can be avoided by making sure that the bougie is not deeper than the black line, or 23 centimeters as marked off on the bougie. If you're able to visualize the laryngeal inlet but are having difficulty placing the bougie into it, it may appear as though the bougie is too soft or floppy to access the airway. This is usually not the case. Far more likely, the operator is standing too close to the patient, and when the bougie is inserted, it is inserted at an angle relative to the line of sight and results in an inability to get the bougie anteriorly enough to access the airway. In this case, merely stepping back away from the patient and lining the bougie up with your line of sight should result in easy passage of the bougie into the laryngeal inlet. If you anticipate a difficult airway, create a 60-degree bend in the distal portion of the bougie. Then, if you're unable to visualize the laryngeal inlet, carefully insert the curved bougie along the curve of the tongue, slipping it anteriorly just under the epiglottis. Confirmation of correct placement must then be non-visual, either by feeling tracheal rings or encountering resistance from the carina at 40 centimeters. The bougie is a simple, inexpensive airway adjunct that can be very helpful when visualization of the laryngeal inlet is difficult.